Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein. Off-label therapies have not been approved for the use specified in this activity. This information should not be considered as a recommendation for the use of a drug outside of the recommendations in the currently approved prescribing information. This activity includes discussion of off-license or unapproved therapies. Please consult your local SMPC or its equivalent for further information.
Hi, welcome to our Medscape session today, where we will discuss the landscape of HER2-mutated non-small cell lung cancer. We'll review evidence, diagnostics, and future directions. I'm Balázs Halmos, a medical oncologist at Montefiore Einstein Cancer Center in the Bronx, New York. And let's start with the basics of HER2 in non-small cell lung cancer. And you guys are all super familiar with HER2 amplification, plays a major role in breast cancer, gastric cancer, some other cancer types. But in lung cancer, the landscape is actually more complicated. HER2 amplification is mainly a rare acquired resistance mechanism where, yes, indeed, it might be actionable. But it's much more important for us thoracic oncologists to think about HER2 overexpression, based on the recent FDA approval of TDXD for HER2. It's high IHC positive cancers 3+, the tissue agnostic approval. And even more importantly, especially for our conversation today, and we need to think about HER2 mutated non-small cell lung cancer, a very specific and now highly manageable subset of lung cancers. And this is a complex subset to begin with. HER2 mutations, which are somewhat similar to EGFR mutations as to their actionability, as to their oncogenicity, most of them occur in the tyrosine kinase binding domain, and they can be quite complex in terms of the readout of the molecular report. Many of them are small insertions, but there's another 10 to 20% of mutations that are just scattered across the HER2 genome, impacting some key domains in the extracellular domain, as well as the transmembrane domain, providing some complexity. But also, I have to admit that there's typically lesser evidence as to the treatment options for those less common HER2 mutations than the ones in the TKI domain. That's just something that we'll have to keep in mind. Why is it so important for the medical oncologists to know all this? Well, because now we have targeted therapy for patients for HER2-altered non-small cell lung cancer, with the recent approvals of trastuzumab deruxtecan for HER2-mutated non-small cell lung cancer. And more recently, we've seen approvals of two highly effective tyrosine kinase inhibitors, zongertinib and savolitinib, for patients with HER2-mutated non-small cell lung cancer, a topic we'll cover in definitely more detail. So briefly, let's just think about ADCs in the second-line setting and beyond. And we'll be mainly focusing on trastuzumab deruxtecan, but let me just mention there's exciting novel agents in development, such as trastuzumab rezetecan as well. So this is now the DESTINY-Lung02 trial looking at TDXD, again, very familiar molecule for most of us, for very specifically HER2-mutated non-small cell lung cancer. And what you can see here is a quite promising 50% response rate or so, two different dose levels being investigated here, 5.4 versus 6.4 milligrams per kilogram. The response rates seem to be identical. You can look at those PFS overall survival curves, very, very similar between the two dose levels. But when we look at safety, definitely the lower dose level logically is safer. There's less grade 3 toxicities, as you can see, just 40% less grade 3 toxicities with the lesser dose, but maybe even more importantly, a significant reduction in the most feared side effect of T-DXd, pneumonitis, from a 32% overall rate to 15%, with very small percentage of high-grade pneumonitis with the lower dose. Of course, there's other side effects. Nausea, fatigue, neutropenia are the top ones to remember when we administer T-DXd to our patients. But let's switch focus to a kind of our more important topic for today. And these are novel tyrosine kinase inhibitors for HER2-mutated non-small cell lung cancer. They're similar, but there's some dissimilarities between the two. Let's start with cevubertinib. What makes it unique, it's actually a dual EGFR HER2 inhibitor, which provides some uniqueness in terms of maybe efficacy, but certainly toxicity here as well. This drug has been studied in the SOHO-01 trial in multiple cohorts of dose expansion cohorts at 20 milligrams twice daily. And you can see the very specific cohorts looking at both pretreated as well as treatment-naive patients. And the primary endpoint of this trial was overall response rate. Here we can see that the overall response rate was actually quite impressive in every single one of the cohorts. Cohort D representing pretreated patients, 64% response rate. But maybe focus on the TKD mutated patients and non-squamous patients, that response rate is even higher at 71%. And when we look at cohort F, and those are the treatment-naive patients, again, this impressive 70% plus response rate is noted. Cohort E looks at patients who received T-DXd in the past, that the response rate is somewhat lower, close to 40%. Many of the responses are durable, with cevubertinib as well. Here you can see the duration of response, 8+ months for cohort D, pretreated patients, and not reached yet for the treatment-naive patients. And that's a cohort we'll discuss in a bit more detail later. The adverse event profile of cevubertinib is actually quite favorable. As I mentioned, it does have some EGFR inhibiting activity, explaining some GI toxicity, some rash that we can see. Diarrhea is the key side effect in a way to remember, but mostly it's a low grade, grade 1 or grade 2. About 14% of the patients had grade 3 toxicity in terms of diarrhea. Of course, diarrhea responds very well, as we've learned through 2 decades of EGFR TKI use, to those halts and those modifications, those reductions. It's actually not a single patient had to discontinue treatment due to adverse events. Serious treatment-related adverse events were rare, and there's no cases of ILD that have been reported. In terms of intracranial activity, I think we'll see a lot more data on this coming out in the coming months, to a year or two. But so far, what's noted is that patients have very uncommonly progressed with new CNS lesions, and patients with prior brain metastasis had excellent activity in terms of overall efficacy of the agent. So likely, hopefully, it has significant CNS activity. Certainly, we want to look at more data to feel confident about that. Here you can see that regardless of how many lines of prior treatment the patient received, as well as independent of the patient's baseline ECOG performance status, here 0 or 1, and the response rates, the benefits seem to be fairly identical. So it can be effective, hopefully, for a very broad population of patients. So moving on to zongertinib, a very similar molecule, but a pure HER2 inhibitor. So it doesn't have EGFR targeting activity. It also lacks EGFR targeting adverse events as a result. This is now the BEAMIO-LUNG-01 trial, looking at the 120 milligram dose of zongertinib, again, in multiple logical cohorts. I might just want to highlight that these cohorts are focused on TKD mutated or non-TKD mutated patients. And I mentioned in our first slide or two, we have more knowledge and likely higher activity for patients with TKD mutation. So when one compares zongertinib versus cevubertinib, one has to remember that these are a little bit more enriched patient population, looking at TKD mutation positive patients, except for cohort 3, which is very specific for non-TKD mutated patients. I actually haven't seen information on that yet. The overall response rate here is the primary endpoint, similar to SOHO-01. And again, impressive data, 71% response rate for cohort 1. This is the pretreated cohort with a median progression-free survival of just about a year. And you can see the responses in the swimmer's plot on the right-hand side. Zongertinib also has a favorable safety profile with a very small percentage of patients with high-grade adverse event. Just 8% of patients had diarrhea. That is still something to remember to appropriately manage. And LFT elevations are highlighted here as well. It's another notable toxicity. So certainly all patients, especially initially, have to be carefully monitored as to LFT elevations. Again, the overall safety is nicely underlined by the fact that only 7% of patients had to dose reduce and only 3% of patients had to discontinue zongertinib. Here you can see that we have a little bit of information coming out in terms of actual intracranial activity, adding patients between cohort 1 and 4, patients who had untreated brain metastases. These are asymptomatic brain metastases at the baseline. And it certainly does seem that the significant activity of zongertinib, about a 40-44% response rate was noted in this small cohort of patients. Certainly we'll need to learn more in this particular key aspect, as many of our patients with non-small cell lung cancer, especially mutation-positive lung cancer, have a high frequency of brain metastasis. So CNS activity is key. Here you can see now patients who actually had received TDXD beforehand as well. This is cohort 5. And you can see that, again, the response rate is lower as expected, but still reasonable at 48%. So offering an option for sequencing between these drugs, certainly there's no overlapping acquired resistance here, and that's logical based on the different mechanism of action. So just briefly about frontline development, cevabertinib, looking at cohort F, I mentioned that previously a little bit. You can just see it here that 71% response rate, and extremely deep responses, durable responses highlight. You can just see the median progression-free survival is not even evaluable because of the excellent durability of responses. And zongertinib in cohort 2 of BEAM-Lung-01 provided very similar data. You can see here the overall response rate is 77%. The 6 months PFS is 79%. So, of course, one thing that we'll need to do now is to make sure that we uncover every single patient who could benefit from these drugs. So testing considerations is very important for us to not leave anyone behind. And number one message that I might make here is that we do NGS testing already for EGF, for Alcross, et cetera. So we do get the ERBB2 information for most of our patients from those NGS panels. But reading it correctly is actually a bit of an art, because these ERBB2 mutations can be listed in a variety of different ways that are not easy to comprehend for the practicing oncologist like myself. So I might say that if you see any ERBB2 alteration highlighted in that NGS report, just make sure that you communicate with your molecular pathologist to understand, is that an actionable oncogenic alteration where you might have an excellent targeted option as opposed to just putting the patient on a standard non-small cell lung cancer treatment path, which would be a shame, and that would be to the detriment of the patient, of course. These are the NCCN guidelines as to testing. Of course, broad molecular profiling has been recommended for years upfront. All patients with metastatic non-squamous non-small cell lung cancer, these NGS panels should and typically do include HER2 as part of the panel. And in patients with squamous cell cancer, this can be considered as well, especially for patients who have limited or no smoking history. So this is my little attempt, how do we actually use these ERBB2 tests? What are they good for? And as you can see, there's not one single test that will cover all of your bases. Tissue NGS, ctDNA will cover ERBB2 mutation testing, but you will need to complement it with some other tests, IHC, FISH, to be able to capture ERBB2 amplifications and ERBB2 overexpression. So the testing paradigm is getting a bit more complicated, and this is how I think best practices, should be utilized. First of all, optimizing tissue acquisition, if possible, reflex testing. We need to be working with our pathologists so that, they are good stewards of the tissue to preserve it for biomarker testing. And yes, indeed, ctDNA testing is helping us so much to be able to facilitate timely and comprehensive molecular profiling. And let's not forget about IHCs, PD-L1, ERBB2, and MET that complement the full biomarker profile for today. And likely this will be continuing to expand. So very briefly, coming to a close here, practical considerations in the real world. But first of all, test your patients, understand the biomarker. But now in terms of treatment sequencing, we have a frontline TKI option, with the alternative being, of course, conventional chemo plus minus immunotherapy and using sequencing of TKI and TDXD afterwards. With that, I have to say that this excellent data on HER2 TKIs and with the great activity, 70% plus response rate, very favorable safety profile, and likely CNS activity, it just seems very logical that these should be our frontline treatment choices for our patients with HER2 mutated non-small cell lung cancer. We learn a lot more as to nuancing and sequencing. There's 3 large randomized phase 3 trials ongoing to understand how the TKIs versus TDXD compares to frontline standard chemotherapy. And we'll see an expanding landscape as to looking at adjuvant use of HER2 TKIs, as to potential combinations up front, similar to FLAURA2, etc. So we'll have to definitely keep our eyes open. There will be more improvements. But what an exciting step forward with the real-world potential use of TKIs upfront, easy oral options with great efficacy, favorable toxicity, and CNS activity. Just a wonderful new chapter for us in thoracic oncology. So with that, I'll be closing here. Thank you so much, and hopefully you'll join us for another lecture next time.